Thank you, Dr. Thank you, Dr. Devang, for including me and giving a nice topic. That's why experience my topic also. So, laser trabeculoplasty means applying multiple laser bond to the trabecular meshwork to improve the aqueous outflow. The historical one is the argon laser, and the recent one is the selective laser trabeculoplasty, that is SLT. So, any procedures on this is a procedure on the iridocorneal angle and was accepted as a second line treatment or alternatively as a first line treatment in selected cases since 2008. So SLE was developed in 1995, and this is a 532 nanometer Q switch frequency double YAG laser, which delivery shots in 1 to 3 nanosecond short pulses, and it selectively targeted pigmented trabecular meshwork, less scarring and coagulative damage to the trabecular meshwork, and no collateral tissue damage, and it is repeatable procedures. So if you compare with LT and SLT, LT causes thermal injury and coagulative damage to trabecular meshwork, and more inflammation and more synechia formation, and it is non-repeatable. Whereas SLT is selectively target the pigment trabecular meshwork and promote cellular regeneration without burn or scar tissue formation, and it's a repeatable procedure. So how will you do? As you already wore a laser, first put the pilocarpine, and if you are going to do a SLT in a primary as a primary procedure, then just put a drop of brimonidine 1 hour prior to the procedure, and they put paracaine to anesthetize the eyes, and the lens used, like this a Latina lens, gonioscopy lens, and the spot size is around 400 micrometer, and the duration is 1 to 3 nanoseconds, and the energy start from 0.6 millijoule of, then you have to titrate till get the champagne bubble appearance. So I tried to get a small video. Yeah. This, if you are expert in gonioscopy, is a very easy procedure. This area, I think, yeah. This area is the focus, and there's a wide aiming beam you can see like this, and then once you aim the trabecular meshwork, just do the laser just in a continuous manner as represented in this picture. Actually, yeah, this is the area. If you a good experience in gonioscopy, it's a very easy procedure, no assistant to do. Yeah, this one in the continuous manner for 360 degree. So what are the post-operative procedure? It's said that no anti-inflammatory drug. If patient complains pain and discomfort, just give on single dose of systemic NSAID. And if you are doing an add-on procedure, continue all the anti-glaucoma medication and manage the IOP spike if happened. Post-procedure pain and discomfort is the most common complaint. Can sometimes have an iritis, hyphema, CME reported, corneal haze reported, and IOP spike. As per definition, IOP spike means IOP raising IOP more than 6 millimeter of mercury just after 1 hour of the 1 hour after the procedure. And this patient have developed peripheral anterior cycle. Recently, I did this patient under SLT for an ocular hypertension as a primary procedure. This patient, this is the first experience for my experience for having peripheral anterior synechia after an SLT procedure. So what are the evidence about the safety and efficacy of this procedure? There are plenty of studies which compare the SLT versus the medications, and a few very early studies compare the LT and SLT also. So what they said, SLT and ALT is almost comparable in efficacy, and some studies say that SLT is slightly upper edge. Regarding the SLT treatment, is overall consensus that SLT treatment is equivalent to in IOP lowering to the use of one medication. That is, it's equivalent analog to another add-on medications. So reported mean range in reduction is 3 to 6 millimeter mercury from the pre-treatment baseline IOPs, and equivalent to 15 to 25% reduction from the baseline IOP, minimum of 7.9 to 35.9 degree, 35.9% reduction as per the reported studies. So, what are the evidence for primary treatment? Now we have tendency for doing as a primary procedure. This is a light trial as a landmark study, multicentric study, which uh, showed that the primary SLT disease progression was less as compared to the number of in medication group. Cataract formation was less as compared to the medication group, and of course the drop related adverse events are less in the SLT group, and SLT resulted a significant cost reduction for the patient. This is another metast analysis which compared the various studies. They took around 8 trials, and they found that SLT is a safe and have a lower incidence of ocular side effects, a safe procedure as a first line treatment in open angle glaucoma. There are other reviews also of it. What all these studies are the cost-effective procedure associated with better quality of life because you can avoid the medication at least for some time. This is also useful in younger patients, also like steroid responders, even reported in good outcome in juvenile open angle glaucoma patients also. So, what are the? You can repeat the procedure. Even the light trial group have reported the efficacy of repeated SLT as a redo procedure. That is, they said the additional SLT maintained a drop-free IOP control in around 67% of the eyes after 18 months of their study. So another study also reported repeat SLT laser resulted in a similar to that. There have the result equivalent to the first SLT. So, is there any role of SLT in an angle closure disease? Uh, there are few studies which reports the efficacy of this SLT in angle closure disease, like more than 3 millimeter reduction in 67% of vision. Narayan Swamy et al. Reported that the good outcome uh, um, for this SLT in a PSCD patients. What we do that we have experienced some good experience of SLT in angle closure disease. Do a laser iridotomy. If a patient require anti-glaucoma medication after laser iridotomy, then you can try a SLT if provided if the angles are open at least 180 degree. That means if you can see visualize pigmented trabecular measure at least 180 degree. So we have our patient shows that more than 4 millimeter of mercury reduction was achieved in around more than 50% of patient without any requirement of further additional medications. So this is a cost-effective procedure, single-time procedure. Many cases you can repeat also. No compliance-related issues. Good IOP control, and the IOP fluctuation may not be good as like prostaglandin. Less ocular or systemic side effect, and safer in pregnancy also. You can substitute the medication in pregnancy. So contraindications are congenital glaucoma, uveitic glaucoma in case where TM is not visible. And to conclude that SLTs selectively target the pigment trabecular mesh without any collateral effect. Enough evidence about its efficacy, cost effective and no compliance related issues. And the good point is it's a repeatable procedure. It provides a better quality of life as compared to your medication. Should be considered as an add-on therapy or as a primary procedure also. Thank you.
Thank you, Dr. Faisal, for such a wonderful presentation and covering this important topic. Dr. Faisal, I had a few questions for you. So you have said that you pre-medicate with brimonidine. So
Yeah.
is there any particular thing why only brimonidine?
No, because Bimoni has some as quick action basically.
Mm-hmm.
If you are doing a cases in a primary as a primary procedure,
Mm-hmm.
then you just give basically some anti-glaucoma medication. I think the reported
Any
is
other?
the
Okay.
Primonin only.
And you prefer to do 360 degree in all patients,
Yeah,
or
we
you
in open angle we usually prefer to do in
do
360
360
degree.
degree?
In angle closure, at least 180 degree.
Hmm. So in angle closures, that basically what you are trying to say is you would like to prefer to do in appositional angle closure rather than cynical angle
Yeah, rather
closure,
than a
right?
cynic. Yes, yes.
So, like, would you routinely do in angle closures right
Yeah,
now?
I think in personal experience, if you compare the baseline IOP of open with patient with similar baseline IOP in open angle and angle closure, I think the angle closure patients are doing better than the open angle glaucoma patients.
Probably because of the increased
Yeah.
pigmentation, right? Okay, that's good to know. And how many times you have to repeat this? Like, how long does this work? One SL, one
I think
treatment.
if it's work. if it's not working, you can see this, like even with 15 days on, from 2 weeks onwards, you can see the pressure is not decreasing. That means your procedure is not efficacious for that patient. Which work at least six months, it can around, it will work it nicely after 6 months actually.
Okay, and then have you seen patients up till 2 years also? It's working
Yeah,
well.
it's very
And longest, how long?
longest we had seen at around 2 to 3 years. I
Two
have
to
seen
three
longest.
years. Then you
Yeah,
have to repeat it. Okay, so one case you had reported, na only one patient you've seen PAS
yeah.
formation.
That's
So
he has
what is the cause for that?
he is a case of ocular hypertension. He had everything's normal, but the pressure is always 40, 50 without any
Okay.
medication. Even if you give everything is pressure like
Hmm.
28, 29 pressure.
Hmm.
So I tried for an add-on procedure as SLT,
Hmm.
but the the PS is also reported in SLT, but that
Hmm.
was my first
That
experience.
was, yeah, that's true. Okay, and what is the post SLT protocol for your patients, and
Uh,
what how do you like
we
to?
won't give any topical NSIDs or steroid.
You don't give
We
anything.
just given a single tablet of uh, diclofenac.
Okay,
That's
pain, just for
yeah,
pain,
just for
and you won't like to continue the medications,
yeah.
or how do
We
you?
continue all the medication because
Hmm.
most of the time we do as an add-on procedure. So we
Hmm.
won't stop the medication
Hmm.
and we call the patient of the first week.
Hmm.
And first week you can expect a slight high pressure. Then after first week, the pressure will stabilize by the
Then you
one
will
month.
try to
Yeah,
wean off the medications.
depends on the severity of the glaucoma.
Okay. And so when the patient comes with a pressure spike in first week, do you like to add oral
That time,
medications or
sometime you need to add an oral
oral
medication. Yes.
medication? Okay. Thank you, Dr. Faisal, for such a good